Hello, this is Zhang Guoli from Beijing University People's Hospital. Here I welcome all the rheumatologists online to attend the APLAR RASG seminar on rheumatoid arthritis. The topics today will be, focusing on the biomarker in RA and the early rheumatoid arthritis. I'm so glad today to co-chair this meeting with Professor Kuni Yamoka, my friend from Kanagawa, Japan. We actually co-chair the SIG in RASG in APLAR. He will chair the discussion and close this webinar today. Today we have two speakers, Professor Fanlei Hu from Beijing University People's Hospital, Department of Rheumatology. He will talk on the biomarker, mainly focusing on the advances of the recent studies in this area. The second speaker will be Professor Yuko Kaneko, Yuko Kaneko, I hope I pronounce it right, from Keio University, Japan. She will talk on the pre-rheumatoid arthritis. So each person have 20 minutes for presentation. We will have a 20 minutes discussion at the last, chaired by Professor Yamoka. Now, let me introduce the two speakers. Professor Fanlei Hu is a full-time researcher in the Beijing University People's Hospital. He is very, productive scientist in rheumatology, focusing on the rheumatoid arthritis mainly. He has published a number of peer-reviewed papers, including the paper he will talk today, I think on the Nature Communications. The second speaker, Professor Kaneko, is from the Keio University, Japan. She has actually over 100 papers in peer-reviewed journals, mainly in the rheumatoid arthritis, arthritis, dural disease, and IgG4 related diseases. So she will talk on the early RA. So today the main focusing will be on the RA, the diagnosis and early RA, which is, I think, a very important area in rheumatology. I hope everybody can catch some information from the two speakers. So now, please, Professor Hu, start your talk. The slides here already.
Thank you, Professor Lee, for your kind introduction. And good evening, dear professors and colleagues. It's really my good honor to present here. Thank Professor Lee's recommendation, and also thank the APLAR RC group for providing this fantastic platform. The topic of my talk today is recent advances of novel biomarkers for rheumatoid arthritis. And before I start, I would like to introduce our team briefly. Our team is the Department of Rheumatology and Immunology, Peking University People's Hospital. And this is our hospital, a not very big but beautiful place which is located in the center of Beijing near the landmark of Xizhimei. And this is our team consisting of more than 110 faculties. And there are 13 professors and 12 associate professors in our team. And this is Professor Zhang Guoli, and this is myself. As the APLAR Center of Excellence, there are 4 parts in our department, including inpatient, outpatient, clinical lab, and basic research lab. RA, FLE, and FF are the mostly commonly studied diseases in our team. And in particular, there are more than 36,000 inpatient and outpatient RA patients per year. As one of the most disabling diseases in clinic, RA has high prevalence in Asia Pacific. And the prevalence in China is around 0.28%, with more than 5 million patients. And in the Europe and America, the prevalence is even higher, around 1%. Although with great advances, the clinical remission rate of RA is lower. And this is one work done finishing from our group under the supervision of Professor Zhang Guoli on behalf of APLAR RAC group. And we investigated 2,010 RA patients from 17 centers of 11 countries. The results show that the clinical remission rate of RA is lower than 35%. Moreover, the clinical remission rate is just about 70% according to the clinical deep remission criteria as raised by our group. There are still many challenges for RA management. One of the biggest challenges is insufficient biomarkers, especially for serum negative RA, which account for 40% of the population. The misdiagnosis of these patients would lead to the delayed treatment and eventually bone destruction and body disability. Autoantigens, B cells, and autoantibodies play important roles in RA pathogenesis. Post-translational modified proteins could induce the activation of
excuse me, Fanny, your slide is not moving. Good now.
Okay. Okay, thank you. The post-translational modified autoantigens could induce the activation of autoreactive B cells and further induce the production of autoantibodies. And these autoantibodies, including the APLAR and the rheumatoid factor, could be used for RA diagnosis. Moreover, these antibodies could precede the disease progression. Studies show that these autoantibodies could appear more than 10 years before the onset of RA, and these autoantibodies could promote the development of RA. And therefore, early diagnosis of RA based on autoantigens, B cells, and autoantibodies have been widely studied. And this slide summarizes the classical RA serum biomarkers. For those RA biomarkers indicated in blue, including anti-CCP, rheumatoid factor, anti-MCV, AKA, and APF, they are commonly used in clinic. Nevertheless, their sensitivity is lower than 60%. For other biomarkers, including anti-CEP1, anti-CARP, anti-RE33, 43 eta, and anti-PD4, because the lack of commercially available kits, they haven't been routinely used in clinic. Moreover, their sensitivity is low. This slide shows some new RA biomarkers just recently by other groups. And today I will just give 4 examples briefly. And the first one is anti-modified protein antibody. As we know, citrullinacein plays important roles in RA pathogenesis. Studies show that besides citrullinacein, carbamylation and acetylation also plays important roles in RA. Anti-citrullinated peptide antibody have been used for RA diagnosis. Therefore, the value of anti-carbamylated peptide, anti-acetylated lysine peptide antibody, and also the anti-acetylated ornithine peptide antibody have been studied. Here are the results. And the blue bubble indicates cis-limited peptide antibody, and the yellow bubble indicates the carbamylated peptide antibody, and the blue bubble indicates the anti-acylated lysine peptide antibody, and the green bubble indicates the acetylated ornithine peptide antibody. And we can see that these autoantibodies show some overlapping, but could also complement the diagnosis for each other. And therefore, these antibodies are collectively referred to as anti-modified protein antibody. And another example is pan-cis-limited autoantigens. One hypothesis proposed that there are autoantigens in all RA patients. Therefore, scientists try to detect pan-cis-limited autoantigens for RA diagnosis. And this is one work done by Professor Chen Zhu, and they designed a multiple cis-limited similar motif with a cis-limited core and cis-limited similar amino acids on both sides. Using this motif, they prepared monoclonal antibodies for sandwich-like ELISA detection. And the results showed that these pan-cis-limited autoantigens show good performance for RA diagnosis, and the sensitivity and specificity is 95% and 94% respectively. And moreover, these autoantigens show the positive rate of about 75% in CCP negative RA. Another example is anti-PDX3 and anti-DSP11 antibodies. And these two autoantibodies were identified by autoantibody screening using serum-negative RA serum with human protein array consisting of more than 20,000 protein candidates. Further large-scale medicine study validation showed that the positive rate of anti-PDX3 antibody in CCP negative RA is about 28%, and the positive rate of anti-DSP11 antibody in CCP negative RA is about 32%. And another example is the biomarkers for refractory RA identified by Professor Peterlis. They recruited refractory RA that are resistant to TNF inhibitor, rituximab, and tocilizumab. And these RA patients were set for synovial biopsy and molecular classification using RA sequencing. In general, 1,277 different expressed genes have been identified. And based on these different expressed genes, they developed a predictive model with the combination of 53 different expressed genes. And this model shows predictive value for refractory RA. And this is the no RA biomarkers identified by our group, because our group have also long been focusing on the screening and identification of no RA biomarkers. And today I will introduce several of our identified no biomarkers. And the first biomarker is anti-HPV 47E2 autoantibody. As we know, viral infection is closely related with RA. Therefore, we retrieved the reference viral sequences from NCBI database and balanced them with the profilogreen peptide, which is also the sequence of CCP1. And the results show that the HPV 47E2 peptide shows a high homology with profilogreen. And therefore, this peptide was synthesized for autoantibody detection. The results show that this autoantibody shows the sensitivity of 41% and the specificity of 92% for RA diagnosis. And another example is anti-PGIY-RP2 autoantibody. And in this study, we extracted circulating immune complex from 10 ER patients and 10 healthy controls for autoantibody screening, for autoantigen identification. And this molecule was identified one potential candidate. Further analysis showed that anti-PGLY2 autoantibody shows a high performance for RA diagnosis, and the positive rate is about 42%, and the specificity is about 85%. Moreover, it also shows a positive rate about 40% in serum-negative RA. And another biomarker is scavenger receptor A, also termed as SRA. In our previous work, we found that SRA knockout mice were resistant to collagen-induced arthritis, indicating that SRA was a potential pathogenic molecule for RA. Therefore, we further detected SRA in RA patients. The results showed that SRA was upregulated in RA patient PBMC on the mRNA level. Intriguingly, it was downregulated on the protein level. And this result puzzled us for a long time. Finally, we proved that this molecule could be cleaved off the cell membrane to form the soluble SRA. And importantly, this soluble SRA was specifically upregulated in RA, but not in other autoimmune diseases that could be easily confused with RA, including SLE, SS, PSA, AUSD, and so on. To further reveal the diagnosis of SRA for RA, we performed a large-scale multi-center study, including one screening cohort and two validation cohorts with more than 3,000 sera. The results showed that the sensitivity and specificity of SRA for RA diagnosis is 66% and 91%. More importantly, SRA could complement the diagnosis for complicated RA. In ERA, within 6 months, it shows the positive rate of more than 50%. And in autoantibody negative RA, it also shows a positive rate of more than 40%. Autoantigens play important roles in RA. Therefore, we also try to detect autoantigenome for RA. And we extracted serum IgG from APLAR positive RA, APLAR negative RA, OA, and Hodgkin cells, and coupled them to the affinity chromatography column for autoantigen isolation. And these isolated autoantigens were further set to high precision mass spectrometry, and the differentially priced proteins were further set to machine learning. Based on the differently priced proteins, we identified and developed a diagnostic model for RA with the combination of 15 differently priced proteins. And the area under the row curve is about 0.99. Moreover, we also developed a diagnostic model for APLAR negative RA with the combination of another 15 differently priced proteins. And this diagnostic model shows good performance for RA diagnosis. Pattern analysis shows superior advantage for disease diagnosis as it incorporates multiple molecules and characteristics. Therefore, we also try to detect different patterns for RA diagnosis. And this slide shows the RA serum proteomic fingerprinting as identified by Moditov. And in general, we identified about 15 differential protein peaks. And based on these differential protein peaks, we developed a diagnostic model in combination of 4 protein peaks. And this model shows the sensitivity of 84% and the specificity of 92% for RA diagnosis. We also try to detect RA serum IgG glycosylation pattern for RA diagnosis. And based on the differentially priced glycans, we developed a diagnostic model for RA in combination of 5 glycans. And this model shows the sensitivity of 53% and the specificity of 90% for RA. Moreover, we also developed another diagnostic model for serum-negative RA in combination of 3 glycans. And this model showed the sensitivity of about 50% and the specificity about 58% for RA. And just recently, we also try to detect RA serum Raman spectrum for RA diagnosis. In combination of machine learning, we proved that the RA serum Raman spectrum shows good performance for RA diagnosis. And in APLAR positive RA, it shows the sensitivity about 19%, 99%, and the specificity of about 99% for disease diagnosis. Moreover, for alpha negative RA, it also shows the sensitivity and specificity of 95% and 92% respectively. And the above are the some of our identified novel biomarkers for RA. And in the end, I would like to give my sincere thanks to Professor Zhang Li for his long-time support and supervision. And also, I would like to thank our collaborators from Virginia Commonwealth University and also the Institute of Biophysics, Chinese Academy of Science. Okay, I think maybe I will stop here and thank you for listening. And this is my contact information and looking forward to collaboration from you. Thank you.
I knew that I wasn't living right. Lie awake for over half the night. I know that I was aiming too low. I felt the pull of the lower tide. Is anybody really satisfied? I don't care. I want the world to treat me fair. And you know I'm aiming up. I'm aiming up. And you know I'm aiming up. I'm aiming up. I met you when I wasn't right. You could see I thought I lost the fight, the war. It was a raging inside. But now I got so much to give. I figured out how I wanna live. And I got to aim it up high.
Okay, thank you very much. Hello, everybody. I am Yuko Kaneko from Keio University. And thank you very much for this opportunity to talk about the recent topic of rheumatoid arthritis. So I am Yuko Kaneko from Japan, and I'm going to talk about pre-RA and D2T difficult to treat RA today. So this is my disclosure, nothing to be declared. So this is the schema which shows the each stage, each phases from A to F to develop rheumatoid arthritis. So combined risk factors, including genetic risk factors and environmental risk factors, such as smoking or microbiota, develops the localized autoimmunity and then goes to systemic autoimmunity. But in this phase, this is not a disease yet. But after that, after a while, after many years, probably 10 years or so, symptoms without arthritis, just like morning stiffness or just joint pain has developed. And after that, arthritis is going on. But in this time, arthritis can be only by sensitive imaging, like ultrasonography or MRI. And then it goes to undifferentiated or unclassified arthritis. And at last, it develops to rheumatoid arthritis. So I'm going to talk about this phase pre-RA today, and the after development of rheumatoid arthritis, the last part of difficult to treat RA. So my first topic is pre-RA. So pre-RA is pre-RA is a nomenclature suggested by Euler in 2014 as the period of developing rheumatoid arthritis before clinically apparent inflammatory arthritis. And this period is characterized with a limited autoimmunity, followed by expansion of innate responses and adaptive responses, inflammation, and tissue injury. Autoimmunity is represented by the presence of specific autoantibodies, including rheumatoid factor or antibodies to steroid-related proteins, carbamylated proteins, and the peptide disminase, which are called, as Professor who suggested that this is now called AMPA, modified protein antibodies. So this is an example of expanding of autoimmunity during pre-RA stage. This study examined sera from military personnel with rheumatoid arthritis and healthy control before and after the rheumatoid arthritis onset. And before the onset of rheumatoid arthritis, the numbers and titers of anti-steroid-related autoantibodies were increased year by year. And another study also used sera from military patients and showed that epitopes and other autoantibodies were expanded before the onset of rheumatoid arthritis. And the number of anti-CCP antibody types were well correlated with the increased levels of pro-inflammatory cytokines such as IL-6, TNF-alpha, GM-CSF, or interferon gamma. So how many patients transit from pre-RA to rheumatoid arthritis? There are several prospective studies which investigated the incidence of rheumatoid arthritis in several positive subjects without arthritis. So one study conducted in Netherlands followed 374 subjects with anti-CCP or rheumatoid factor positive without arthritis for a median 12 months, and identified that the 35% of the subjects developed arthritis and 32% of the subjects developed rheumatoid arthritis. So another study conducted also in Netherlands followed 55 subjects with anti-CCP positive or rheumatoid factor positive without arthritis for median 30 months, and identified 27% developed arthritis after 13 months. And another study conducted in the United Kingdom followed 100 subjects with anti-CCP positive for a median time of 7.9 months, and the 50% of the subjects developed arthritis, and 43% of the subjects developed rheumatoid arthritis. And another study conducted in the United States followed a little bit small sample size, but 35 subjects with anti-CCP positive for a mean time of 2.6 years, and found that 40% of the subjects developed arthritis. So overall, approximately 30% to 40% of seropositive subjects are likely to develop arthritis during 1 or 2 years. So genetic background is also a very important factor of developing rheumatoid arthritis, as well as seropositivity. So one prospective cohort conducted in the United Kingdom followed 370 subjects, unaffected subjects who have rheumatoid arthritis patients within first-degree relatives, and they were followed for a median time of 5 years, and they identified that the 3.8% of the subjects developed rheumatoid arthritis after 5 years. And another prospective cohort conducted in Mexico gathered 819 initially healthy subjects of the 252 patients with rheumatoid arthritis. And among them, approximately 5% was seropositive, and 2.1% developed rheumatoid arthritis during the 5-year follow-up period. And another cohort conducted in North America, including Canada and Alaska, gathered 374 unaffected subjects, relatives, who have rheumatoid arthritis patients within first degree relatives, and they were followed for the mean time of 4.7 years, and they 24% of the subjects developed seropositive, and approximately 5% developed arthritis for a mean time of 5 years. So the overall, several percent of the subjects who have rheumatoid arthritis patients within first degree or second degree developed rheumatoid arthritis during a median time of 5 years. So a report from the prospective cohort from the Netherlands made a predictive scoring model using those risk factors, including first degree of rheumatoid arthritis, no alcohol, symptoms of less than 12 months or intermittent symptoms, symptoms in extremities, fast pain more than 50 millimeters, morning stiffness more than 1 hour, allegedly reported swollen joints, and the combination of anti-CCP or rheumatoid factor positivity. So they found this model showed that the higher the score becomes, the higher the probability of developing rheumatoid arthritis becomes. So a cohort investigating military people showed that the inflammatory cytokines, elevated inflammatory cytokines, and anti-CCP positive or its combination predicted the developing rheumatoid arthritis development in future. And the sensitivity is not very good, but specificity is very good. And another prospective cohort conducted in the Netherlands identified smoking and obesity as a strong risk factor for developing arthritis. So the hazard ratio of developing arthritis is 9.6 for smoking and 5.6 for BMI more than 25. The likelihood of of subjects with autoantibodies for rheumatoid arthritis, such as rheumatoid factor or anti-CCP antibodies, and smoking and obesity to develop arthritis is very high. So maybe stopping smoking and weight loss may prevent the development of rheumatoid arthritis. So pharmacological drug intervention has been tried to prevent the development of rheumatoid arthritis. So the trial of maybe we can call a PRIORY study randomized investigated the effectiveness of rituximab to prevent rheumatoid arthritis development. So they randomized 81 individuals who were positive for both anti-CCP and rheumatoid factor, but without arthritis, randomized to single rituximab bolus of 1,000 milligrams versus placebo, and follow the patients for a mean of 29 months. And during the observation period, 37% of the patients developed arthritis with rituximab, and 40% of the subjects developed arthritis with placebo. So the risk of developing arthritis that was reduced by the rituximab 55%. But this study, the final instance of developing arthritis is not different, and rituximab actually decreased the anti-CCP or rheumatoid factor titers, but the decrease in anti-CCP and rheumatoid factor titers were not so different, and it was not effective to prevent developing rheumatoid arthritis in individuals with seropositivity of anti-CCP or rheumatoid factor. So this is another study to investigate the effectiveness of dexamethasone to prevent rheumatoid arthritis. So this study randomized the 83 individuals who were positive for anti-CCP or rheumatoid factor without arthritis, and into intramuscular dexamethasone 100 milligrams bolus or placebo at baseline or at 6 weeks, and follow the patients for a meantime of 26 months. And during the observation period, dexamethasone decreases antibody titers, both anti-CCP antibodies and rheumatoid factor titers, but arthritis developed in both groups in almost 20% in the dexamethasone and 21% in the placebo groups. So the bolus intramuscular administration of dexamethasone didn't prevent rheumatoid arthritis development. So this is another cohort which investigated the effectiveness of atorvastatin to prevent rheumatoid arthritis. So this is called STRA trial, randomized to 62 individuals with a high titer of APLAR or APLAR and rheumatoid factor double positive without arthritis into daily atorvastatin or placebo, and follow the patients for a meantime of 14 months. And during the observation period, 29% in the atorvastatin group and 19% in the placebo group developed arthritis. So unfortunately, the statin is unlikely to prevent development of rheumatoid arthritis. So this is a very famous study called the PROMPT study, which investigates the effectiveness of methotrexate. So this study was conducted in 2014, and it randomized 110 individuals with undifferentiated arthritis into methotrexate or placebo, and follow up for 5 years. And methotrexate actually delayed the development of rheumatoid arthritis, but only in APLAR positive patients, and it only delayed the progression. So the most of the patients developed rheumatoid arthritis. So then the same Netherlands group conducted the treat earlier study. They included 236 individuals with arthritis, just joint pain, and with MRI detected subclinical arthritis. And the patients were administered 120 milligrams glucocorticoid and methotrexate or placebo, and followed up for 2 years. So at 2 years, the frequency of arthritis development was similar between the two groups, 90% in the methotrexate group and 80% in the placebo group. And the hazard ratio was 0.81. So similar to the previous PROMPT study, the benefit of methotrexate was delaying the developing arthritis was observed only in APLAR positive patients. And in conclusion, methotrexate, the cornerstone treatment of rheumatoid arthritis, if initiated at the pre-arthritis stage and with just the subclinical inflammation, did not prevent the development of clinical arthritis. So, but of note, methotrexate modified the disease course and improved MRI detected inflammation. So there are several trials now going on to investigate the usefulness of early drug intervention to prevent rheumatoid arthritis development. And abatacept is the most promising drug, and the results have been waited. So the next topic is the second topic is the difficult to treat RA. So despite the treatment according to the current management of recommendations, a significant proportion of patients with rheumatoid arthritis remain symptomatic. So these patients can be considered to have difficult to treat RA. And last year, you defined the terms of difficult to treat RA. And number one is treatment according to your recommendations and failure of two DMARDs or TSDMARDs with different mechanism of action. And the second criterion is the presence of at least moderate or high disease activity, or the signs or symptoms suggestive of active disease, inability to taper glucocorticoid below 7.5 milligrams per day, or rapid radiographic progression, and still having symptoms. And the management of signs or symptoms is perceived as problematic by the rheumatologist and or the patient. So how many patients are D2T-RA in clinical practice? This is our data from Keio University cohort in Japan. So we have 1,700 patients with rheumatoid arthritis, and almost 60% of the patients are treated with biologic agents or targeted synthetic DMARDs. And among the 173 patients, 11% met the criterion of, according to CDAO-28 of the D2T-RA. The reasons of D2T-RA were multi-drug failure, comorbidities, or socioeconomic reasons. So our study shows that the reasons of D2T-RA are very various, and the individualized treatment is needed in the management of D2T-RA. So a prospective cohort in the Netherlands reported among 152 patients with rheumatoid arthritis, 34% were met the criteria of D2T-RA. And they further classified the patients into three groups: non-adherence medication and dissatisfaction, and pain syndrome, and obesity, and smoking. And 50% of the patients can be truly called refractory and resistant to multi-drugs. So this is Professor Fan Wei Fu also introduced, but this is the collaborative work of this RAC group of APLAR. When we looked at the remission rates among countries participated in the collaboration, there is great difference among countries. But in every country, the remission has not been achieved in more than half of the patients, and there is a need for improvement of the management of rheumatoid arthritis. So this is again the Keio University cohort data. So we further identified 77 patients who were not classified to D2T-RA according to the D2T-RA criteria, but they were still in moderate disease activity or high disease activity. And they were not classified to D2T-RA because they didn't try 2 or more biological agents or JAK inhibitors, which means that the patients or their attending physicians were reluctant to intensify treatment because of comorbidities or some reasons. But those patients are not classified, but they are also very problematic in clinical practice. And this is the results of a survey that was conducted among worldwide rheumatologists 2 years prior to the development of D2T-RA definition. And the survey identified that the fatigue is also a very problematic signs of D2T-RA. And they, some of the 43% of the rheumatologists wanted to decrease the prednisolone dose below 5 milligrams per day, not 7.5 milligrams, but below 5 milligrams. So the definition of D2T-RA may be reconsidered in future to refine the definition. So this is my summary. And there is a growing need to identify patients with pre-RA and establish the optimal intervention to prevent the development of rheumatoid arthritis. An accumulation of findings of D2T-RA patients are needed to clarify the characteristics of D2T-RA and refine the treatment. Thank you very much for attention.
Okay, so I'm Kunihiro Yamaoka from Kitazoto University in Japan, and I would like to thank Professor Hu and Professor Kaneko for the great presentation. I think it was very interesting. They both touched on the early RA, pre-RA, and also the late phase of RA. And Professor Hu touched on biomarkers, autoantigens, autoantibodies. Professor Kaneko focused on very clinical perspective view, also using their own KO cohort. So I would like to encourage the participants to submit any sort of questions. It can be very naive question. I think the great two professors can answer your questions. So please submit any sort of question that you have in the chat box. And until we have questions, I think I will probably start from Professor Hu's presentation. I just wanted to first ask, can you sort of explain the last presentation that you had which was called the Raman spectrum, which you had 99% sensitivity and also specificity?
Yeah, thank you, Professor Yamaoka, for your kind question. Maybe I think I will try to answer your question, and Professor Lee will give his comment later. And in our study, we tried to detect the Raman spectrum for eye diagnosis. And this is a new technology just proposed recently. In fact, a Raman spectrum has been discovered more than, maybe I think, let me try to check. Yes, it was first discovered by the Indian scientist Raman in 1928, about 100 years ago. And this technology won the Nobel Prize in Physics in 1930. And so, which is the Raman spectrum? As we know, when light enters the transparent medium, it will scatter. And usually the frequency of the light will not change, and this is called the Raman scattering. And another kind of scattering is with change the frequency, and this change frequency is called Raman scattering. And why the frequency of light changed? Because the molecular vibrations and rotations in the transparent medium. So this spectrum could reflect the molecular characteristics of the medium. And this technology has been widely used for the drug discovery and drug structure, and also some chemical component analysis. Just recently, this technology has also been used in some disease diagnosis. And in our study, we try to use this technology for eye diagnosis, and also with the combination of machine learning, we prove that this technology shows powerful diagnostic value for RA, and also the sensitivity and specificity is more than 90%. And also in alpha negative RA, it also shows superior advantage in diagnosis. So I don't think whether it's answer your question or not. Maybe I think Professor Lee will give his comment also.
So I just want to sort of wrap up, is that you sort of combine all the informations and look for, you combine a lot of biomarkers that you have measured, and you do the analysis to sort of come up with a algorithm that you can diagnose correctly with the RA patients. Is that sort of idea that you have? Is it correct?
Yeah, it combines different molecules, mostly including the peptides and also small metabolites. Also, so
okay. Okay, thank you very much. We are having some questions, so I don't want to miss them. So I think I will go on to the questions that have been submitted.
Let me just add quickly
sure.
just a few words to finalize comments. The Raman technologies really are very sensitive to pick up the tiny molecule. The problem now we are actually experiencing is we cannot see much difference between the different samples, say RA, even OA visually. We have to do it through machine learning. Then the signal will be picked up, show us a very sensitive and specific value. So that's at the moment we are working on try to modify the technology with our collaborator in Beijing to see whether we can see the difference between the pattern or the way we can call visually. That'll be much better. So rather than through a machine learning, because practically, so in clinical, it's difficult to use it in the daily practice. So hopefully the problem will be solved in the future.
Oh, okay. So 99% of sensitivity and specificity is really, very attractive. So I think the question submitted here is probably for Professor Kaneko, and maybe if Professor Hu can add on something, please go on. I will read up the questions. Could you please mention your approach to treating D2T-RA in your center, Professor Kaneko?
Okay. I'm sorry I didn't mention about that, but our approach is very similar to the Euler proposed the approach to difficult to treat RA recently. Then our approach is very similar to that one. So if patients have not responded to current treatment, first of all, you should check the diagnosis is correct, if the diagnosis of rheumatoid arthritis is correct. So there are several diseases similar to, which symptoms are similar to rheumatoid arthritis symptoms. So you should check the diagnosis. And after that, rheumatoid arthritis diagnosis is correct, you should check there is arthritis or just this is a symptoms. So probably the sensitive modality, including the ultrasonography or MRI, is very useful. But you should check there is arthritis or not. And if there is arthritis, still arthritis, you should check the reasons for not responding to treatment. So there are some patients who have not truly responded to current treatment, and we can call those patients true refractory RA. But maybe patients do not take medication very well, or some other causes the arthritis. So you should check the reasons of not responding to treatment. And after that, you should decide how to manage the rheumatoid arthritis.
Professor Hu, do you have something to add on? There were questions for treating D2T-RA. So.
No, I just have a different question to Prof. Kaneko.
Yeah.
So you mentioned the definition of D to T RA need to be redefined. So I have the same kind of similar feeling. It's very difficult now to define it. In our center, we found that I should say the percentage of the patient probably like 5%.
Oh,
very low. So what you are thinking if you say to redefine the criteria?
Yeah, it's a very difficult and very important question. And as I mentioned earlier, in my institution, 11% of the patients are difficult to treat RA, but many of my friend rheumatologists say that it is very low, surprisingly low. But you mentioned that your institution 5% is very, very low. So maybe the definition of DTRA is not very good, or I'm sorry, I don't have any idea to improve the definition, but maybe the definition should be improved and to detect more patients who have not truly responded to rheumatoid arthritis treatment.
Yeah. Okay. Another related question actually is about the treatment. So from the literature just you reviewed, seems there's no, I mean, this will be not really related, talk about the pre-RA. So do you give any medication for patients with pre-RA, say just see maybe as joint pain with positive CCP? If you do, what do you use?
Yeah, currently I don't administer any medication to pre-RA or subjects with just joint pain without arthritis. But I'm not sure if this is correct. Maybe some medication would delay the rheumatoid arthritis development. So I am waiting for the some effective treatment to prevent rheumatoid arthritis, and I am waiting for the results of the trials now going on.
Right. Yeah.
So
from the West, the publication. Sorry, you can see they use from England, from states use very, to me, it's very strong. The medication. The probably in Japan, the opinion or the all feeling are similar. We don't want to give a patient like a high dose steroid or the very strong medication. In China, we sometimes in my clinic we use hydroxychloroquine. Some patients.
Yeah,
but no data now. Don't know whether it will work or not. It seems working. We need a study.
Yeah, hydroxychloroquine has not been approved for rheumatoid arthritis in Japan yet, so we cannot use hydroxychloroquine.
So in that terms, like pre-RA stage, I think Professor Kaneko touched on the possibility of abatacept, the ARIA study, but also the treat earlier study. I think it was pretty impressive, methotrexate. But we have some problems in Japan, and I think it's something I would like to know. How do people in China think about, or physicians think about, this effect of methotrexate in pre-RA? Is it something that you get really excited and reluctant of giving methotrexate in these patients? Or I don't feel that at all for Japanese.
Certainly, I think there's, as far as I know, there's no very designed, well-designed the RCT on MTX in pre-RA. But for some rheumatologists, they by their own interest, maybe use MTX for pre-RA. For the patient, maybe really pain, just painful, but even no swelling affects their life. Probably you can use it.
Well, Professor Lee, my question was, Professor Kaneko presented the treat earlier study with methotrexate in patients that have been proven by MRI only. So this is subclinical joint inflammation. So they have been treated very early pre-RA stage. Maybe they can be RA, but I think Professor Kaneko knows that at the, there was not really an effect to prevent RA, but when they once had RA, the pain and swollen, the patient treated with methotrexate was better. But I think it's nice, but I just don't feel very comfortable treating pre-RA patients with methotrexate just because we have certain problems in Japanese population. So I just thought how Professor Lee and Wu would think about treating Chinese RA patients, pre-RA patients with methotrexate.
Actually, I couldn't hear you. Your microphone is not very clear.
Okay, sorry.
Yeah.
Okay, can you hear me?
Yeah, now it's better.
Okay. So anyway, let's move on to another topic that has been submitted by the audience. This is also something presented by Professor Kaneko. It's about the psychiatric comorbidity and also fatigue. So this is a really complicated story, I guess.
Yeah.
And the question is, how do you treat them? How do you do it in your clinic? And I would like to ask Professor Hu, do you have any comments on like biomarkers for something like this for fatigue? So Professor Kaneko first, please.
Yes, thank you, Professor Yamaka. And my question is, although some biomarkers have been identified for pre-RA and difficult to treat RA, and they are not easily to be used for daily practice in clinic. So my question is, are there any biomarkers identified by your group that could be easily used in clinic?
I don't think so at the moment. My question was, do you have any biomarkers that comes up with you for fatigue in RA patients?
Okay, sorry. We haven't touched on the issue, and just for RA diagnosis and for the combination, especially the fatigue, we don't have some biomarkers right now.
I think this is a sort of a topic that is coming up, and I think Professor Kaneko is also working hard on it. But I think in reality, I think it's really hard to sort of deal in the clinic. What do you do? Is there any suggestions that you can give for the audience? Professor Kaneko?
Sorry. Yeah, it's a very important but very difficult to answer. Yeah, the fatigue is very problematic. And if patients have active disease, active arthritis with fatigue, we can treat patients with some anti-rheumatic drugs. But if patients don't have arthritis or don't have probably visible arthritis, but still complain fatigue, it's very difficult to solve. And sometimes the intensifying arthritis treatment may be effective, but maybe there is psychiatric problems with fatigue, so it's very difficult to differentiate from true activity fatigue from psychiatric problem or some other causes.
Yeah, I think it can also be related to depression. And also, I think there is a sort of a hesitancy from the patients that they don't want to go to the psychiatric department.
Yes.
Or not the psychiatric.
Yeah.
How about that in China?
Yeah. Actually, this I don't know whether you could realize or not. Some of the patients maybe have RA patients D2T. Maybe with fibromyalgia. I didn't hear what you mentioned. No, fibromyalgia is it's a very common problem with RA. In China, we have some, not like in Japan. Several years ago, actually more than 10 years ago, when I was in your Congress people in Japan talk a lot about fibromyalgia. For the prevalence is very high, like I feel 6 or 7%. In China, rare. So, what's your opinion on this?
RA patients with fibromyalgia.
It's also very difficult problem. Making a diagnosis of fibromyalgia is difficult, isn't it? Very difficult, isn't it? So we can't say you are definite fibromyalgia. There is a possibility of that kind of pain comes from the arthritis disease activity or subclinical arthritis disease activity. So it's very difficult, I think. But how do you diagnose patients with fibromyalgia in China?
Yeah, I think we use the similar or the same criteria, but really it's not that often in our clinic. Probably because the patient with RA in this country have maybe workload are much higher than in Japan. Probably they have to work. They just forget about the muscle pain.
Okay, Professor Lee, I think we ran out of time, but since I am sort of running this Q&A session, I just want to ask one more question for Professor Hu. You showed a very interesting data on the scavenger receptor A, and what I wanted to ask you is that there were a lot of patients, or a very small portion of patients that had very high scavenger receptor A level. And what is the difference of the patients that has very high and those that don't?
Yeah, thank you, Professor Yamaka. Yes, for the serum scavenger receptor A, there is a proportion of RA patients that with high level, and we try to find the characteristics of these RA patients. And our preliminary results show that most of the patients have high CP level and also especially high rheumatoid factor level. And also in the elderly RA patients, they have higher levels. And also for those patients with higher SRE level, they tend to develop to the bone destruction and closely correlated with this bone destruction.
Okay, thank you very much. I think it was really interesting, and I hope we had more time to discuss about it. But maybe in the future and also at APLAR, I would like to close this session with first thanking all the participants. You know, it's Saturday night. Everybody have a nice evening. Have some beer or alcohol or whatever you have in your hands, and have a nice dinner. And thank you very much for attending. And also Professor Hu and Professor Kaneko, thank you very much for your nice presentation. I think it was very interesting from different perspective from each of you, looking into early RA, pre-RA, and also the B2T RA patients. And Professor Lee, thank you very much for co-authoring, co-chairing this session. I think it was a very nice Saturday night, and I hope it will be a nice Saturday night for everyone. Thank you very much and good night.
Thank you very much.
Thank you, Professor Yamaka and Yuko. Yeah. Thank you so much for your talk, for your sharing. Hopefully we can have some collaboration in the future in RA.
Yes.
Also everyone, let's see you at APLAR.
See you at APLAR. Okay. Bye-bye. Thank you.
Thank you very much.
Take care.
Bye.
Lay down, hold me closer, and I no turning